Okay, so you can share your screen, Kathleen.
Yeah, okay.
Okay, so.
Okay, so now you see my screen. Everybody sees my screen then now.
No,
I don't anymore.
No, I saw it before, but now we don't see it.
Ah, okay, that's strange.
So I just accepted something right now, and then it's changed. So I thought I got the invitation now to become presenter as well, but
Yeah, but then I have to change it because so normally, Kathleen, you should be able to share your screen. Can you do that?
Yes, but I already did that.
Can you try it again? Because I don't see your screen.
Where presenter has control. Show screen then? Okay.
Yeah, now it's okay.
Okay, everybody, okay.
Okay, so the few things you need to know. So basically, Kathleen, you will move the slides also when Titia will present.
Yeah.
Okay.
So Titia, then you will need to say next slide if I'm not going.
I can try on WhatsApp if there's any delay that I can kind of.
No, I think we're fine. You know, we hear you well.
Next slide.
The only thing, Titia, the only thing you just speak close to the microphone.
Yeah, I can. You don't see me at all, do you? I can try with my earphones in.
No, we don't see you. We don't see you.
You don't see me neither, eh?
No, we don't see anyone.
No, so I can try still changing with a earphone if that makes it better.
Well, we can hear you,
Yeah.
but if you speak like this, it's fine. Before it was a little bit not loud enough.
Okay, I'll try to speak on this level.
Okay, try to speak. So what basically I do is that I usually introduce the two of you. I give a few directions, and then you give the webinar, and then people basically can write questions.
Mm-hmm.
And I will ask the question at the end of the webinar. Usually the webinar is around 30 minutes.
Yeah.
And we have roughly 15 minutes of questions.
Mm-hmm.
I usually start around 4 o'clock plus 1 minute. And, you know, just by introducing you, I will waste another 3 or 4 minutes, and this gives time to people to join the webinar. Yeah, and in general, the maximum of attendees is around 4:15. So this is where you should put your best slides.
Okay. That's too late. You should have said that earlier.
So the attendees peaked at 4:15, and because a lot of people are late, and then it starts to go down. But you will see. So I see people coming up, you know, and they will join. So now that we know that we have a good connection, what I would suggest is that I turn off my microphone, and then I will turn it on again 1 minute before 4 o'clock. Is that okay for you?
Yeah, that's okay.
Okay, so we'll see each other in less than 10 minutes. Okay?
Yeah, that's perfect. And we can do the same, hè?
Yeah.
Titia, moeten wij nog iets af?
Nee, volgens mij niet. De onderverdeling vond je goed?
Ja, dat is prima. Ja. Dus ik zal ook heel kort over die CKD 1-2 gaan, totdat je... En die general rules, dat doe ik kort, omdat we anders toch te veel... En dan begin jij terug bij dialyse en transplantatie en dan eindigt jij ook, hè?
Ja, precies. En ja, ik denk dat als we op 30 minuten moeten uitkomen... Ik zal de klok mee hebben lopen. Ja, je ziet het ook. Dan is het denk ik lang genoeg. En ik zal... we kunnen misschien op een goed moment zeggen dat ik zal zeggen dat we Piccolo hebben uitgekozen en dat Zhang ook een hele goede meta-analyse heeft geschreven en dat die nog op het einde zit. Want we zijn natuurlijk een beetje beperkt op sommige plekken. Maar ja,
Ja, dat is zo. Maar ja, we hebben maar een half uur.
ja dat kon niet anders. Dus ik denk dat zal ik nog wel... nou, als jij het niet zegt, dan zeg ik het. Dat blijft een beetje improviseren.
Ja, dat
Maar,
is effectief ook zo. Ja, dus we kunnen een aantal dingen gewoon niet doen. Hè.
ja, maar goed. Nee, ik denk dat het een heel mooi verhaal geworden is. Ik ben benieuwd.
Ja, ik ook.
Wel leuk zo.
Ja, zo is iets anders, hè?
Ja, zo. Met z'n tweeën. Nog nooit hebben we elkaar live bewust heb ik je gezien.
Maar we moeten misschien als we elkaar ooit tegenkomen. Hè?
Ja, ik vind het een leuke samenwerking. Het ging heel
Ja,
goed.
ja, zeker zo. Ja. We gaan dan Albertine ook doorgeven dan, hè?
Ja, zeker.
Ja.
Dat kan ik zeggen. Dat vind ik heel gelukkig.
Ja, voilà. We
Maar
zullen
goed,
straks zien, hè? We moeten het nog doen.
nu nog de uitvoering.
Ja,
Ik zet,
voilà.
maar dat
Kijk,
groene knopje.
dat is,
Ja.
kan je dingen. Dus ik ga die nu ook even afzetten. En ik zal die ook afzetten. Ah ja, jij bent weg. Ja, voilà.
Ja.
En ik ga die ook afzetten als jij aan het spreken bent, hè?
En ik als jij dus, want dan hoor je niet mijn achtergrondgeluid.
Ja, voilà. Ja.
Oké. Maar dan geef jij aan, dan zie ik natuurlijk dat ik het weer overneem.
Wat zeg je?
Dan zie ik dat ik het weer overneem en dan moet ik het me even aanzetten.
Ja. Dus jij neemt over bij Impact, dus CKD on Pregnancy. Hè?
Dat is heel
En
leuk.
dan neem ik Pregnancy on CKD. En daar hebben we zang wel genomen. Hè? Dus op zich
Ja, op zich komt hij er wel. Ja,
komt het
nee.
er wel in. Hè? En dan effectief, dus dan weer de piccolo. En dan die general rules ga ik dan snel over, want dat is eigenlijk een herhaling van het vorige. En dan doe jij terug de dialyse en tot op het einde. Hè? Dus dan moeten we maar 1 keer switchen. Hè? Ja, 2 keer switchen. Hè?
Ja, anders werd het 6 keer. En toen dacht
Ja,
ik,
dat was te veel. Ja, klopt. Dat was echt te veel. Nee, dat is prima.
Oké.
Oké,
Nou,
goed. Tot ziens. Ja, bye.
Okay, I've turned on my microphone. Can you hear me?
Yes, Titia.
Okay,
Yes, I can.
okay.
Can I
So,
just ask one small question? If you see my screen, do you see the dashboard as well?
no, but you know, the only thing that you may want to do is that, do you have pop-ups for your email or something like this?
I turned off my email, but only
Everything that,
from the
so,
software from my that will. But my email is turned off normally. I can
yeah,
double
so
check. Just
we
double.
see your screen. So anything that comes up on your screen will be seen by everybody.
Yeah.
Okay,
Okay.
so
Just let's
that's
hope
the only,
there's nothing important coming
no,
up.
no, it will be okay. So if you agree, then I will start the webinar now.
Yes. Perfect.
Hold on, where do I start the webinar? Where does it start?
I have here a question. Start broadcast, so I can do that.
Can you start it, because I don't know how come I don't see it.
Maybe because I'm set as an organizer.
Oh, you're set as an organizer, so you
But
should
you're an
start
organizer
again.
as well, so you should.
So you started. So can you?
I push start broadcast now. Then okay.
Okay,
Yeah.
just go ahead. So good afternoon, everybody, and welcome to this ERKNet webinar. My name is Francesco Emma, and I'm speaking from my office in Rome. As usual, before starting, let me remind you that your microphones are turned off, but that during and after the webinar, you can send your question through the application that is present on your screen. I will ask your questions at the end of the presentation. The webinar will last approximately 30 minutes. We will then have 15 minutes available for questions. We have two speakers today. The first one is Professor Kathleen Claes, who is a nephrologist in the University Hospital of Leuven in Belgium, with a special interest and expertise in genetic kidney diseases, rare renal diseases, and pregnancy in patients with renal diseases. In our institution, by the way, she's a member of the executive committee of the University Hospital of Leuven. And then we have Professor Titia Lely, who is a gynecologist at the University Hospital in Utrecht, with an expertise in maternal medicine and especially in the renovascular field. She's an associate professor, and her translational research focuses on kidney diseases, preeclampsia, and fetal growth, with a specific interest on novel therapies for hypertension during pregnancy. So by this presentation, you would guess that the title of the talk today is Pregnancy in CKD. So please, Professor Claes.
Yes, I will start by welcoming you all to this webinar on pregnancy and the kidney. I usually start with these quotes from The Lancet from more than 40 years ago when I was a toddler. And at that time, women were advised against getting pregnant when they had renal disease. Unfortunately, we have come a very long way since then. And we now are convinced that all women with a pregnancy wish with chronic kidney disease should be counseled, but more importantly, should be counseled timely. And that's timely. We will discuss that later on. What's the main reason for this? So if we look at what are we going to tell today, what are we going to discuss, we're going to start with some physiological changes. It will be quite briefly, and then we will discuss how we counsel our women when they want to get pregnant. And we will discuss some special situations as well. But due to the time constraints, because we only have 30 minutes, we will not be able to discuss everything we wanted to discuss. So we left out acute kidney injury, preeclampsia, and drug treatment in pregnancy, but we will give some backup slides later on. And what I would like to emphasize as well is that a couple of days ago, I think yesterday, there were some guidelines published from the Renal Association from the UK, which are guidelines for clinical practice guidelines for patients with CKD and pregnancy. So if you're interested in this topic, it might be interesting to have a look at these guidelines as well. So I will start with the physiological changes. So there are several changes that will occur during pregnancy, and we all know that the kidney sizes increases in length 1 to 1.5 centimeters during pregnancy, and the kidney volume increases up to 30%. And this is primarily due to an increase in renal vascular and interstitial volume. And also the collecting system will dilate, mainly due to the effect, the hormonal effect, but also there might be some mechanical compression of the ureters. Pregnancy is associated with a widespread vasodilatation, with an increase in arterial compliance and a decrease in resistance. And then you can see a decrease in your blood pressure as well. And the increase, and this will lead to an increase in GFR as well. And as you can see here, the increase in GFR is seen within 1 month after conception, so very, very rapidly. And there's also an increase in renal plasma flow as well in the beginning of pregnancy. Later on, the renal plasma flow will return to normal or after pregnancy, a week after pregnancy, but your GFR remains elevated. So you will get a decrease in serum creatinine levels. So that means that if you have a woman with 0.9 milligram per deciliter or 1 milligram per deciliter in your outpatient clinic who is pregnant, that's not normal creatinine value. So you have a patient who's pregnant with kidney disease. What is important as well is that there's an increase in proteinuria to 150 milligrams a day in the 3rd trimester, and more than 300 milligrams a day is said to be abnormal. Other physiological changes I will not go into detail are respiratory alkalosis, which is a mild hyponatremia and glucosuria, and the latter is due to a decrease in tubular glucose reabsorption. So we will start with a case. This is a patient who was followed in the outpatient pediatric clinic because of reflux nephropathy, and she had some renal insufficiency, but unfortunately she was lost to follow up. But she remembered that her pediatrician said that if she wanted to become pregnant, that she needed to be counseled beforehand. And so at the time that she wanted to get pregnant, she went to a nephrologist, and we saw her for the first time, and she had a history of hypertension. She was treated with metoprolol, and she had some renal insufficiency with a serum creatinine of 1.7, an estimated GFR of 39, so a CKD stage 3, and a proteinuria of 1.2 gram per gram. In the office, her blood pressure was 145 or 85. So how are we going to counsel this lady? So what is very important is when we see these women in our outpatient clinic, we need to be aware of their thoughts as well. What is the perspective of the women who come to our outpatient clinic regarding pregnancy? And this is a systemic review of 15 qualitative studies, and there were 7 major themes. You can see them here: pursuing motherhood, the failure to fulfill social norms, but also some fear or insecurity about birth defects, transmitting genetic disease, what will happen with my graft, what will happen with my renal function, what will happen with my child. So these are the things that we need to address when we see those patients on the outpatient clinic. So there are some general rules. Which patients will we need to see? Well, who should be referred for pre-pregnancy counseling? And there we have the women with CKD stage 1 and 2, with adverse risk factors, significant proteinuria, hypertension, or with an active systemic disease such as lupus vasculitis or diabetic nephropathy, or patients who had a previous adverse obstetric history. And then women with CKD stage 3 to 5, we need to see them all. Women with renal transplants, and also women with a family history of hereditary renal disease. What is very important, but we'll discuss that later on, is the multidisciplinary approach. The gynecologist, the nephrologist, genetic counselor, and also the neonatologist if needed. So regarding the underlying disease, we need to know what is the underlying disease. And as you can see here, the most common causes are the most common causes of young adult patients, the younger population with chronic kidney disease. But some underlying disease deserve more attention regarding the timing of conception, but also regarding some specific risks. For instance, patients with CACUT or patients with reflux nephropathy, they have a higher risk of urinary tract infection. So maybe they will need to start with prophylactic antibiotic if they have a urinary tract infection during pregnancy. For the hereditary risk, we will discuss that later on. For the timing of conception, for diabetes, they need to have an adequately controlled blood pressure and glucose. Lupus nephritis, their disease needs to be quiescent for 6 months. And for glomerulonephritis, there need to be a disease that's stable as well. Blood pressure needs to be well controlled, and we need to switch to non-teratogenic treatment. I will discuss a bit further on the genetic counselor. About 25% of patients with chronic kidney disease have a family history, somebody else in the family who has chronic kidney disease or was on dialysis or transplanted. In 10 to 20% of patients with chronic kidney disease, there is a Mendelian course. And if we go to the younger population, this is even higher. And there is in the pediatric population, there was a study for renal transplant candidates up to 25 years, and in 33% there was a monogenetic cause. And in 10% of patients with chronic kidney disease, we still do not know the cause. So there will be in those category of patients genetic causes as well. Here you see 20% of end-stage renal disease before the age of 25 to 30 years are monogenetic hereditary, and we have learned a lot since the last decades. The last 20 years we have learned a lot. We have seen that there are some new roles for all genes, for instance the collagen 4A genes, where they used to be X-linked Alport, but now we know that collagen 4A3 and 4 are associated, are causing focal sclerosis in the family as well. What makes it difficult for counseling is that there can be a difference in penetrance of the disease and difference in phenotypic variability. So that might be for some of the diseases difficult for the counseling. So a genetic counseling needs to be addressed, and we need to think about it, and it needs to be done for the inheritance risk. Is it an autosomal dominant disease? As I said before, the phenotypic variability and also the variable penetrance of the disease. We need to discuss the prognosis of the disease, and patients need to be aware of their options. And here are some categories of patients that we discuss also pre-implantation genetic testing. So what are the options for couples who are confronted with an increased risk of a child with a genetic disease? These are the theoretical options. So they can conceive naturally without tests, with the risk, if there's an autosomal dominant disease, of 50% that the child gets the disease. Conceive naturally with prenatal diagnostic tests. That's something that we in our centrum very rarely do. It's an exception. You can go for sperm or oocyte donation, adoption, or decide to have no children. But what is an option now, and what we discuss and what needs to be discussed if it's available in your country, is a pre-implantation genetic testing or embryo selection, where the unaffected embryos are selected, identified, and before implantation are identified, and that it will prevent genetic diseases in the following generations without termination of the pregnancy. So it depends on the disease severity, the patient preference, but also the local availability. But I am convinced that the patient should be aware of this option if it's available within your country. It's not a walk in the park. As you can see here, there's some preparation time, hormone treatment, so it's very invasive, it's time consuming, and the success is less than a spontaneous conception. So, and what we also discuss with our gynecologist as well, who is going to do the treatment, is that we recommend in patients with chronic kidney disease to do a single embryo transfer to reduce the risk of the complications during the pregnancy. This is only possible when the mutation is known, but genetic counseling is also necessary for non-monogenetic diseases. For instance, for CACUT, we always see the patients together with the genetic counselor to discuss that there is a wide array of possible phenotypic variability in the children. So what is the impact of chronic kidney disease on pregnancy? And now Titia will take over for the next couple of minutes. Titia?
Yes, thank you. Next
Yeah.
slide. So when women with kidney disease do get pregnant, they have an increased risk for adverse outcomes because, of course, the vascular function, the hypertension has effects on the placenta that grows into the mother. Next slide, please. So what are those risks? So some women with CKD already have hypertension before pregnancy, but as well others who don't have hypertension are at increased risk to develop hypertension or at risk to develop superimposed preeclampsia. This can persist post-pregnancy. Mostly it resolves and can have permanent effects on the kidney, which we'll discuss later on. We see in all the populations published so far that there is an increased risk for prematurity, dysmaturity, and because of those complications, there is an increased risk for a C-section and increased risk for induction as well. But it varies really depending on the population and the local ways of mode of delivery as well. So prematurity and dysmaturity both have long-term consequences for the neonate, like neurological impairments, lung problems, cognitive function, and women need to be explained on beforehand how this is depending on the stage of CKD they are in. I'm going to show you some data on that topic the following slides. And as we not going into detail in this presentation, there are certain drugs that are used in pregnancy, in kidney disease especially, who have effect on the development of the fetus. We know nowadays a lot on safety issues, but we don't know a lot on the long-term effects of therapies. Next slide. So there are several cohorts, and one of the largest cohorts that has been published on CKD and pregnancy outcomes is an Italian cohort in which you see across the stages from stage 1 until stage 4, 5, an increased rate of adverse outcomes. If you look, you see that the numbers are for CKD 4 or 5 are low, are just 10 patients, and for 2 and 3, they're considerable. Most women have CKD 1. Next slide. And if you focus on the fetal outcomes in the middle, you see in this Italian cohort a C-section rate of approximately 50%. In our center, it's approximately 1/3 of the patients with kidney disease get a C-section, which is a double rate from a normal population. If you look on the gestational age across the CKD stage, you see that women with CKD1 deliver around 38 weeks, and in CKD stage 4 or 5, around 33 weeks. So that gets really into prematurity, and that's depicted into the birth weight as well, around a normal birth weight of 3 kilograms in CKD1 and up to 1,600 grams in CKD 4 or 5, and a need of admission rate in the NICU intensive care unit for the babies of 70% in CKD 4 or 5. So there's very likely to be an event in an advanced CKD stage for the child. And if you look at the mom, we're going to discuss it in the further on slide, you see as well in this slide depicted that there is CKD stage shift or renal replacement therapy start in 20% of the patients in stage 4 or 5. Next slide. So if you combine all these things together in one graph, you really see that if you become pregnant in stage 4, it's really something that you need to know all these outcomes, and as well the consequences for both mom and baby. And if you have a very stable stage 2 or 3, these outcomes, and especially since the last 20 years, NICU care got much better all over the world, that we consider these outcomes well enough to not be worried about the child. Next slide.
So now I'll take over. As a nephrologist, I will discuss the impact of pregnancy on the chronic kidney disease. And the risk of renal deterioration during pregnancy remains a concern, and there is conflicting evidence at this time. This is a meta-analysis by Zhang, and here you can see there is no association between pregnancy and deterioration of renal function. And this is irrespective of etiology or baseline stage, but in these meta-analysis, there are not a lot of studies with renal insufficiency in a later stage. Here you can see that the deterioration, this study from Limardo, there you can see that there was some decrease in renal function, so that the renal function was less at the start of the study, but he did not show in his meta-analysis that there was a difference between in the outcome after pregnancy compared with non-pregnant women. But if we go to the older literature, and there you have some landmark studies like Davison and Jones, and in the beginning of my career, we took the set point of 2.4 and later on of 2.8, and then we would say to the patient, yeah, this is a very high risk, we still do so. But then we use these studies to counsel the patients. And here you can see that in the study of Jones, which was a mix of etiologies, there was a renal function in women with moderate to severe chronic kidney disease during pregnancy and postpartum, and there was a transient deterioration in 43% and a permanent deterioration in more than 25% of patients during pregnancy and after pregnancy. So permanent deterioration in 1/3 in the patients with a later stage of chronic kidney disease. And that's now how we still counsel the patients, that if the stage 4 and 5, there is a higher risk of permanent damage to your kidneys. So Piccoli, I will discuss that further on in the next slide. And in Basciati, this is also rather small studies. As you can see, all these studies are rather small. But in this study, Basciati found that pre-pregnancy estimated GFR below 40 with a proteinuria of more than 1 gram predicted renal decline after pregnancy. And then the other risk factors are very important. If you have a renal function if you have a renal insufficiency, but no other risk factors like hypertension or proteinuria, then your outcome is better than if you have the other risk factors. So if we counsel the patients, I always talk about hypertension, proteinuria, and renal function. Here is the study from Piccoli, and here you can see stage shift or start of dialysis in stage 1. You can see that 4.8% of the patients have a shift in chronic kidney disease. So they went to stage 2, and in stage 4 and 5, new onset hypertension in more than half of patients, doubling or onset of proteinuria in the majority of patients, and a stage shift or start of dialysis in 20% of the patients. So there was a shift, evidence that pregnancy accelerates early CKD is limited, especially for early CKD, but deterioration is more likely with more advanced renal disease. So for our patient, she comes to our outpatient clinic. She has hypertension. She's treated with metoprolol, and we will not discuss it, but we will change this treatment. And now she has a CKD stage 3 and a proteinuria. So she has the 3 risk factors. So she's high risk. So she needs to be counseled and follow up during pregnancy properly. So some general rules, I will not discuss it into detail because it's more or less a wrap up of the slides that we discussed before. There's a risk of preeclampsia in all stages of CKD, which is higher than in normal pregnancy. There's also a risk of preterm delivery, a risk of low birth weight, and the risk increases with the presence of other risk factors like proteinuria and hypertension. And also this risk is cumulative. So I also always tell my patients that 1 and 1 is not 2 in these cases, 1 and 1 is 3. So if you have hypertension and a more advanced stage of chronic kidney disease and proteinuria, this is the highest risk of patients. So CKD stage 3 and 4, there's a greater loss of the fetus, preeclampsia in up to 40 to 60% of patients, prematurity. But as Titia said before, the NICU care has improved so much that we discuss the risk with the patients, and then the patients afterwards discuss again with the gynecologist, with the nephrologist in a second interview what they think about the risk, and then we just, when the risk is increased, we increase the follow-up in our outpatient clinic. So the study of Imbashati, if the clearance is below 40 and a proteinuria of more than 1 gram, there's a higher risk of renal deterioration. So now we go to specific situations, pregnancy on dialysis, and there Titia will take over once again.
So the combination of pregnancy and dialysis is rare, and it's still an exception, but a recent cohort from Canada has shown improved outcomes. So there are more cases coming in the last years. Fertility loss is one of the most important reasons why women don't become pregnant, but as well, of course, all nephrologists advise not to become pregnant because of the maternal and both fetal risks. There is a loss of fertility because of the hormonal influences, but there can still be a menstrual cycle, and most of the time it's irregular. A lot of women, but as well men on dialysis experience sexual dysfunction. Peritoneal dialysis and pregnancy is even reported less, and is accompanied with a lower implantation rate, but successful outcomes are reported as well. And of course, it can be accompanied by peritonitis, which is again associated with premature birth. Next slide. One of the important things to know is that urea is fetotoxic. In the past, intra-amniotic injections of urea has been used for therapeutic abortions. And if urea is really high, above 21, there are no successful pregnancies reported. And that's one of the main things. When women do become pregnant, you need to get as stable levels as urea as possible and intensify your dialysis. Yes. So what there are around the world approximately around 1,000 pregnancies in dialysis reported. Of course, there are more present, but one of the largest comparisons during the past years was one from Canada compared to a cohort in United States. In Toronto, there are a lot of women on nocturnal hemodialysis with larger hours of approximately 40 hours a week. And when comparing these two cohorts, incredible changes in pregnancy outcome were reported. When you see look on the pregnancy outcomes in the United States cohort, you see a birth weight around 1,700 grams on average, with a live birth rate of 34%, of 61%, sorry. And if you look at the Toronto cohort, you see approximately a birth weight of 2 kilograms with a live birth rate of 86, of above 85%. So that's really something that we consider as gynecologists an okay outcome in a high risk population. When the dialysis was, of course, started off in pregnancy, there was worse outcome. Next slide. And when you look on the question about the amount of dialysis hours, which you see on the left graph, and a live birth rate, you see 3 tertiles. The first tertile of between 0 and 20 hours of dialysis, the second tertile between 20 and 36, and the third tertile above 37 hours of dialysis. You see increased birth rate, and as well a survival of the kids. And this was really the point where we said, well, maybe some women which are very stable and can't conceive a renal transplant in the coming years, this could be an option. But these kids from Toronto were all unplanned pregnancies. Next slide, please. So afterwards, in 2015, a meta-analysis on all international dialysis and pregnancy outcomes were reported. And if you look into the question how much you should go up with your hours of dialysis, you see this graph, you see less preterm birth if you intensify your dialysis. And of course, the study from Heldunovic really is the outlier in this graph. And we don't know the optimum amount of hours, but we see clearly that if the patient is more stable in urea levels, but as well on hemodynamic parts and other toxic substances, the outcome becomes better. Yes, continue. So what recommendations can be made? And the NEFSAP, you might all know, there was one published on pregnancy with a lot of useful information for the clinics in 2016, and this is a table with all the recommendations for pregnancy. I won't go over in terms of detail, but one of the most important things is of course to intensify, as we just discussed, in hours, to really look at stable low blood pressures post dialysis, but as well consider preeclampsia monitoring, which is of course quite difficult. It is a diagnostic dilemma in dialysis, but as well in renal patients. Yes, it's okay. We can continue. The last topic is pregnancy and renal transplantation. We won't discuss the immunosuppressive therapy, but we'll have it in the additional slides. Antihypertensive therapy is, as in other kidney disease patients, and when to consider pregnancy after is that you really need to have a stable transplant function, and the amount of years after transplantation differs from guideline to guideline, but most recommend 2 years after transplantation. And sometimes you do need to switch immunosuppressive drugs because CellCept, for example, you can't combine with pregnancy. Next slide. So talking on, again, pregnancy outcomes, my topic is what do I expect with a stable transplant function? These represent 3 data sets. The part 2 is one which is not published yet. That's a Dutch data set. It's the New Zealand, Australia data set, it's the UCAS and the UK data set. And you see similar rates with a mean gestational age of 36 weeks, birth weight around 2.5 kilograms, prematurity level around 50%, low birth rate of around 40 to 50%, and very low birth rate with long-term consequences of around 14%. And we see that increasing in our Dutch data set, and that's because we have become more liberate with allowing women with even less graft function to become pregnant, with, of course, worse pregnancy outcome. And stable, we see around 20% of intrauterine growth restriction, a birth placenta below the 10%. Next slide. So if you question then again, will pregnancy have influence on my graft function? This was a meta-analysis performed by several students of mine who is now in press. And if you look onto graft function, 2 years, 2 to 5 years, 5 to 10 years, and more than 10 years, in the different studies, it's really comparable graft loss compared to a non-pregnant population. But of course, only the well-functioning grafts are conceiving. So there's a bias. Yes, next slide. So if you look into the comparison case control between pregnant and non-pregnant, which are matched for several parameters of the graph, you see, you can continue with the slide, is that that there are no significant differences in graft loss between cases pregnant and non-pregnant in reported. Next slide. Yes, again, next slide. So then an important question, which we already raised previously, is that is the extra demand on the kidney, on the graft, does that deteriorate after pregnancy? And there are a few small studies that report serum creatinine 2 years, 2 to 5 years, and 5 to 10 years postpartum, with only a small significant increase in serum creatinine when you look shortly postpartum. But the amount of data on long-term and GFR slope, for example, comparing pre and post pregnancy are not available yet. But we think that the small change in serum creatinine, which is only 0.2, is really maybe a publication bias. And in the part 2 network, in the Dutch transplant cohort, we are now currently looking at GFR slopes before and after pregnancy. And the first initial analysis did not show any change of GFR slope before and after pregnancy, which kind of suggests that pregnancy is safe for well functioning grafts in terms of GFR in a transplant patient. Next slide. So this is again showing that the preeclampsia risk is around 30%, a meta-analysis from Despande from 2011, showing that that's quite high compared to normal population. And then what can we do to prevent the preeclampsia and the placenta dysfunction? So both growth restriction, preterm birth, and hypertension, preeclampsia in pregnancy, and that's giving aspirin. Giving aspirin between 8 and 36 weeks in a low dose before the night gives a reduction of around 10%. This is a meta-analysis and gives you an indication for as well other indications to give aspirin. Apart from, we think, is strict control of blood pressure, of course, very important for pregnancy outcome. Yes. So I addressed already the topic a little bit on the diagnostic dilemma of superimposed preeclampsia versus worsening of the kidney disease in pregnancy. And this can be very difficult, of course, because the physiology is that you demand extra from the kidney in the 3rd trimester, and of course the fetal growth on the ultrasound can help you, but as well we know from recent studies that androgenic factors can help you, which are released from a dysfunctioning placenta. They can help you to distinguish between the 2 types. And on the left you see both soluble FLT, the androgenic the receptor from VEGF, and PLGF, and the red line depicts a subtype group of superimposed preeclampsia. The green line is late onset preeclampsia, and the other line depicts a normotensive group. And you see clearly over time that those lines separate and that there's a different pattern in both the pro and the anti-androgenic factors. PLGF is a pro-androgenic factor secreted by the healthy placenta. Endoglin might help as well. And this is another study from the Brits, from Braham, showing similar curves over time for PLGF on the right. Next slide. So as already mentioned in the beginning, a multidisciplinary approach is necessary both before pregnancy, but as well in pregnancy, to give optimal care for both mom and baby. And on beforehand, it's very important to do the genetics well in advance and to discuss the option when necessary, when available, for pre-genetic testing. Genetic tests can take for a long time, so we advise women already to come quite a few years ahead before they really want to conceive. And we discuss in pregnancy a lot with our neonatologists when premature delivery is arising, to prepare parents on the premature delivery, and sometimes even when it's very early, to discuss whether we should be active or not. Thank you.
Okay. Well, thank you both very much for this extremely interesting webinar. So please send in your questions, and I will ask them for you. And again, I personally learned a lot, and I will start with a few questions that I have. First of all, you mentioned obviously MMF that needs to be discontinued. Can you make some comments on how you adjust the rest of the immunosuppression in patients that are pregnant, and in particular in patients that have increased blood pressure during pregnancy? Do you modify your immunosuppression?
Titia, what is important for your immunosuppression is that both tacrolimus and cyclosporin, you need to check your trough levels, because in the beginning of pregnancy you might need, because of your increase in your plasma volume, you might need an increase in dose. So it's really important to check the trough levels. And then we also adjust our antihypertensive drug, but it's not that we are going to switch from tacrolimus to cyclosporin because of a higher risk of hypertension or vice versa. But for tacrolimus and cyclosporin, you need to be aware that you need to check your trough levels in the beginning of pregnancy quite regularly and during pregnancy as well. And for, so I'm going to our backup slides. So these are the antihypertensive drugs that we in our center usually use, being the labetalol, methyldopa, and the Adalat. We're now using more and more the Adalat, so the nifedipine long-acting. I'm sorry, I just put in the brand names in Belgium. So the nifedipine long-acting calcium channel blocker and the labetalol. I don't know, Titia, if you want to add something to that.
Yeah, I think we do it quite similarly with the immunosuppressive drugs. With antihypertensive drugs, the Dutch guideline still recommends metildopa as first choice, but as you as pointed out over there are quite some adverse effects, and we nowadays know from several trials in pregnancy is that nifedipine is much more effective, but until now there were not so many safety data on nifedipine, so we're a bit more so it wasn't our first choice until now, but nowadays we're as well as like you increasing to give nifedipine because it's much more effective, and there is enough safety data right now to consider it.
And also, if patient is on both tacrolimus and CellCept, we will switch to I don't know, maybe that was his question as well. We will give them azathioprine, so we will switch beforehand, long beforehand, and then we usually see for at least 6 months whether the graft function remains stable before we really give the green light.
All right. Okay. Thank you. So Dr. Yavari is asking you to comment on male transplant recipients who decide to have a child. When after transplantation do you think is the best timing? Do they need to do a drug shift? So this is the question for you.
We are not shifting the drug from MMF. I think that's the question. We are not doing that, but we are informing our patient of the drug warning. And for timing, we do not. We usually also advise them to wait for a while after transplantation, to have more a stable setting after transplantation. But at this time, we do not switch the MMF. I don't know if that answers your question. We also wrote a letter about this. I don't know.
But let me complement the question. Do you think that there is any risk of adverse of birth defect if a male patient who just got a transplant and is on heavy immunosuppression drug father a child?
Yes, what we do is we advise them to have a stable, so it's more or less usually also a year after transplantation to have a stable. So if they're on high dose corticosteroids, that's probably not the best setting. So we usually advise them to wait also for a half year, a year after transplantation, but not the 2 years for the women. So if they have a stable drug dose as well.
Yes, and is this based on hard data, or is this?
No, not that I know. I'm not aware of. No.
And actually, just to complement, Dr. Davison is asking, what do you do with MMF with the fathers? Because as you know, there might be actually there's some data. Do you stop it or not?
We don't stop it. No. So you also wrote a letter. There are some data from the Scandinavian country which are quite reassuring. So we do not stop the MMF. Is Dr. Davison stopping the MMF?
So you were questioning
I just wanted to know about the audience whether they are.
Let's see if he answers that. Yes, that is the advice that is given in the UK.
Yeah.
And actually, Albertine van Erde was also pointing out that we should always keep in mind that the fathers may have a genetic disease.
Yeah, that's true. Yeah. That's the same. Yeah, that's true. Yeah, it's the same.
And Dr. Yavari is also pointed out, and I apologize if I don't pronounce well the name, is also pointing out that they also switch to azathioprine male patients from MMF.
Male patients as well, yeah.
At least 3 months prior to conception. And Dr. Davison is also complementing his answer. He says, we consult with regards to a theoretical risk with MMF, and hence usually advise stopping MMF.
Yeah.
And we also have a message from Bert Bummens, who has no questions but would like to congratulate you on organizing this webinar. And so
Okay,
this is a
thank you.
compliment for you.
Yes,
Let's
regarding
see.
the MMF, I think there's still, I think we are still waiting for the hard data. Patients need to be informed, but we are not at this time not switching. Yeah.
And again, you're receiving a lot of compliments also from Dr. Davison. Maybe we will leave the webinar open 5 more minutes if you have additional questions. Let me ask you one thing. What do you say to your patients really when they come to you and let's say they have a compromised renal function? So you show us all the data, but at the end of the day, if a patient comes to you and asks you what are the risks, let's say it's a transplant patient with not a normal renal function with CKD 2 to 3, what do you say in practical terms?
I will let Titia answer that question. Yeah.
So it will first address the point that Kathleen pointed out, is that I want to know the additional risk factors of that patient, like hypertension, proteinuria, stability of the renal function during the past years, and then and the type of drugs used. And what we basically do is always provide systematic approach. So first, tell the patients what is the effect of the kidney disease on the pregnancy, and I will draw the data basically from Piccolo cohort and explain what I expect for the birth weight and the gestational age and the risk for the baby in terms of prematurity and long-term consequences. Afterwards, when that message got received, we will discuss the effect of the pregnancy on the kidney, which is, we now know, is quite okay in most situations. And then we'll discuss the medication changes that are needed, and those medication changes could have effect have on the kidney as well. And finally, we discuss the genetics and the possibilities of a genetic cause of the kidney disease and the consequences for the child. Mm-hmm. And as well, I think the social situation, and in terms of worsening in renal function and needing more care, and the social support system, how that is arranged, and the possibility of getting a renal transplant or being on dialysis in the future, and how that is, as a young parent, we'll discuss those aspects as well. And we do that in Utrecht, those counselings with 2 doctors together, and we refer afterwards to the genetics. So we do it together with a gynecologist and a nephrologist to really discuss interactively with the patient those aspects, especially in advanced CKD.
Okay.
So we do it a bit, I don't know if we do it a bit differently, very briefly. So we used to do it together as well, but now we're doing it separate. So we give the same information, and it's more or less the same as Titia just told us, but one of us will do the first, and then the patient will go to either me or to the gynecologist, and then the patient can already address the questions they have. But we as Titia said, we just say what's the impact on the pregnancy, what's the impact of the pregnancy on the renal function. So we do it more or less the same.
Okay, and so basically, if I understand you well, I think that both of you, if patients have a reasonable renal function, will be relatively reassuring. And I will ask you one last question, then we'll end the webinar. Is there when would you advise against a pregnancy? Is there a situation where you would discourage pregnancy?
Sometimes, yeah, Titia,
go ahead.
just start. Yeah, just start.
Yeah, so there are rare cases where we do it, but it's I think once or twice a year that I do that with a renal patient. But most of the time, there's a lot of comorbidity with, for example, the antiphospholipid syndrome, a very bad functioning renal transplant with and earlier pregnancy failure very early with severe preeclampsia. So we do it, but quite rarely. Yeah.
Okay. Okay.
So
Thank
with
you.
very high maternal and fetal risks.
Yeah, for us
Okay.
it's the same. Yeah.
And Kathleen, do you want to add something?
No, it's the same. It's quite exceptional that we advise against, but it occurs. And sometimes
Okay.
we just say wait until after transplantation.
Okay, thank you both for this extremely interesting webinar, and thank you everybody for attending. You've seen the slide with the next webinar by Dr.
I
Vidali
will
in
go
a
back.
few
I'm
weeks'
sorry.
time,
Here.
which he will talk about non-infectious complication of peritoneal dialysis in children. So you're all welcome to attend this new webinar. And again, thank you all and have a very good afternoon.
Okay, thank you. Bye-bye.
Bye. And I think, Kathleen, you will have to end the webinar because
Okay, and
you
then
have the commands. Okay.
stop. Now I just need to find where I have to do this. Options. And the LMR.